Basically, we'll just go for the cases, and as we all know, the osteoporosis is a common problem for all. 55-year-old male patient, history of road traffic accident, few days back, severe low back pain, and this was the X-ray and CT scan. Yes, Sanjay, Dr. Masa, what's your take? What we should do for this patient? L4 wedge compression fracture.
First, we do the conservative treatment, and then the pain is still there, so we think about balloon kyphoplasty, the kyphoplasty.
So it's a fresh, stable fracture, no neurological deficit, radicular pain, no sagittal imbalance.
You can treat it really conservatively because it is not at the dorsal lumbar junction.
So we treated it conservatively, no neurological deficit, stable fracture, and very well treated conservatively. 60-year-old female patient, history of sudden jerk, treated conservatively for 2 months, severe pain while getting and these are the X-rays and MRIs.
Now here you can see definitely
There is a fluid-filled
non-union.
cavity, and yes.
Non-union. So
Yes.
this is the case for augmentation, either vertebroplasty.
So Dr. Bhandari says that we should go for the augmentation vertebroplasty. Incapacitating pains, maintain sagittal alignment, no neurological affection. How much cement you will use? Whether you will do a vertebroplasty or kyphoplasty?
About 4 to 6 ml of cement usually.
4 to 6 cc of cement, vertebroplasty, kyphoplasty.
But I will go for vertebroplasty. Because
Yes,
I don't have
Dr.
perception.
Masa, what's your take on this?
To tell the truth, vertebroplasty is not allowed in Japan, so we always do kyphoplasty because of the primary embolism. Our government don't allow.
Your government doesn't allow, but you feel vertebroplasty and kyphoplasty results are same.
Kyphoplasty.
Yes. So there is a fantastic article by Dr. Abhay Nene et al. And he has given this algorithm wherein which if there is a vertebral compression fracture and there is a non-union, if there is no neurological deficit, we should go for the conservative treatment. If there is no neurological deficit, fracture healed, which was the first case. If the fracture is not healed, we can go for the vertebroplasty. And in this case, we went for the vertebroplasty. Patients of vertebroplasty versus kyphoplasty results are same. There was an intervertebral instability, that's a pseudoarthrosis, Kummel's lesion, no sagittal imbalance, so no stabilization which was done. This is a 68-year-old male patient, severe back pain since last 3 months, loss of bladder and bowel, bilateral hip weakness, and this is the picture. Yes, anybody would like to take on this?
He will require long segment fixation with neurodecompression
Yes.
along with augmentation. You may do cement augmentation of the level also.
So all the panelists, yes, what you would like to do? You would like to do a cement augmentation and posterior stabilization?
Yes, long segment posterior fixation and anterior column reconstruction, augmentation.
Dhar Saab, what's your take on this?
No, since there's a significant kyphosis, so I would do an open surgery and push the fragment in and maybe put a
Yeah, so there is
long segment.
a loss of sagittal balance, there is a bony retropulsion. So it was just decided and just done what all the panelists are suggesting. Direct decompression, posterior stabilization, neurological decompression which was achieved, and whatever was compressed and pseudoarthrosis in front has been augmented in this case. So basically went to cement whenever there is a intravertebral instability, whenever there is a Kummel's lesion, we can go for the vertebroplasty and kyphoplasty, and whenever there is an intervertebral instability or the posterior stabilization has to be added. So we say when we should do a opportunistic DEXA scan on BMD scan, if it is more than -2.5, then in those cases we can supplement with cement augmentation. 72-year-old male patient, severe low back pain since last 3 months, decreased activity due to pain, bilateral hip weakness, and this is the MRI. How you would like to treat this? Skip lesion, skip vertebral fracture, neurological involvement. No sagittal problems. Yes, Dr. Masa, your take.
Maybe PPS from thoracic to pelvis.
So there is a multi-level fractures, neurological compromise. So you like to do decompression and stabilization?
Just stabilization is enough.
Just stabilization, no decompression.
I mean like, indirect decompression.
Indirect decompression. So in this case, the indirect decompression, direct decompression which was done and cement augmented screw fixation was performed in this particular case. So basically, this is the last case wherein which this was an ankylosing spondylitis. This patient had a fall and there was an instability. This is how this patient was. His chin brow and gaze vertical angle, they were very, very damaged, and this is how his picture was. What you would like to do?
Because the spine is fused, most probably he will require long segment fixation along with the augmentation, vertebroplasty.
So augmentation, you mean vertebroplasty?
Yeah, you can put the cement in that level and to step.
So in osteoporotic fracture, it is paramount to get a CT scan to see the integrity of the posterior wall of vertebral body. In this case, the posterior wall is damaged and it is not advisable to do a vertebroplasty. Yes, Dr. Masa.
Okay, I am a deformity surgeon, so this is definitely the sagittal alignment is not so good. So VCR or maybe the PSO,
So-
we should realign the
Yeah,
sagittal
so
alignment.
pedicle subtraction osteotomy, some osteotomy correction and long stabilization would be the choice. So basically this algorithm and this paper I will recommend everyone. One of our esteemed faculty, Dr. Abhay Nene, he has published in European Spine Journal. So I will just go through all this flow chart. If there is no neurological deficit, if there is a Kuhlman's lesion, go for the vertebroplasty. If there is a neurological deficit, if there is a intravertebral instability, and if there is a intervertebral instability. So if there is a what is intervertebral instability? If there is a superior end plate fracture, and if there is a intervertebral instability, we can just go for the posterolateral decompression fixation. If it is less than 30-degree kyphosis, we can go for transpedicular decompression and stabilization. If there is a more than 30-degree kyphosis, we can go for pedicle subtraction osteotomy and posterior stabilization. So I will like to stop at this case and will like to give a take-home message that whenever there is a intravertebral instability and sagittal balance is maintained, we can just go for a cement augmentation. If there is a sagittal balance is lost, we can go for posterior tension band. If there is a neurological deficit, we can add a decompression and posterior stabilization.
Thank you,
very much.
Ketan. Thank you.